Good morning, everyone. So, on behalf of Medicine Unit 4, I'll be presenting on the topic Yellow, Not Mellow. Presenting our case, a 28-year-old gentleman who's working as a farmer from Tiruvannamalai, presenting complaints of fever with myalgia for 2 weeks, vomiting and loose stools for 10 days, melena, and one episode of hematochezia just prior to the presentation, and breathlessness and diaphoresis for 5 days. Fever, which was high grade intermittent and associated with myalgia and tiredness, for which he went and sought medical care from local hospital, for which after which he did not have an improvement. Vomiting and loose stools persistent with decrease in appetite, and the loose stools were not blood tinged and non-mucoid. And subsequently, he developed to have one episode of fresh blood in stools just prior to the presentation, followed by which he was also complaining of a breathlessness, which was worsening and associated with diaphoresis for the past 5 days. Past history, he has no other comorbid conditions. He had a history of walking barefoot in paddy fields in this recent monsoon season, and he's a reformed ethanol consumer. This is on examination. Just like a spotter, he was grossly icteric. He was conscious on it, this having distress on presentation and mild pitting pedal edema in the dorsum of foot, and grossly icteric with right subconjunctival hemorrhage also noted. Vitals on presentation was a pulse rate of 115, which was low volume in and regular, blood pressure of 90 by 60, which was fluid responsive, and then improved to 120 by 90. He was tachypnic and he was hypoxic on room air. Systemic examination, he was tachypnic with usage of accessory muscle for respiration, and bilateral fine basal creps were noted. Per abdominal examination showed a palpable liver of up to 3 centimeter below the costal margin. Cardiovascular system and central nervous system examination was normal. Now, in the epidemiological context of a South Indian farmer presenting with an acute febrile illness with jaundice and one episode of bleeding manifestations, my differential first will be considered as a leptospirosis with multi-organ dysfunction, and other differentials being the dengue with warning signs, or a rickettsial infection, scrub typhus with multi-organ dysfunction, or a viral influenza with multi-organ dysfunction, and malaria, viral hepatitis, bacterial causes like enteric fever, or any other hemorrhagic viral fever caused by hantavirus, etc. Now, this is the symptomatology presentation of various causes for AUFI. As in the case of leptospirosis, there will be jaundice as predominant with conjunctival hemorrhage, vas suffusion, and myalgias, and thrombocytopenia, shock, and renal dysfunction as a common presenting complaint. And the other differentials, the respective symptomatologies is described on the slide. Now, in our patient, we had the relevant investigations. Leptospiral ELISA was positive, and the other two bloodborne viral screening because of the gross icterus state, it was negative, and he did not have any coagulopathy. Other relevant investigations, his hemoglobin was 10.3 with an MCV of 79, and counts were normal, 7,000. Platelets showed thrombocytopenia, with smear showing less than 15,000. And his renal functions, urea was elevated with creatinine of 6.33 on presentation, and electrolytes being sodium 138, potassium of mild hypokalemia, and bicarbonate of 15. His LFT on presentation was 14.17 of total bilirubin and direct of 12.35, which was subsequently increasing. And another fact that to be noted was a mildly elevated liver enzymes of SGOT of 129, SGPT of 100 on presentation. Chest X-ray showed a fluffy opacities in bilateral lung fields, suggestive of a non-cardiogenic pulmonary edema. Now, looking at the during the course of hospital stay, his jaundice was worsening with the serial elevation of the total and direct bilirubin pointing towards a cholestatic jaundice. And his renal functions, he did not get any renal replacement therapy. So serum creatinine was in the lowering trend during the course of hospital stay. Now, with the history and examination and the positive ELISA test of leptospiral antibody, we have come to a diagnosis of severe leptospirosis or Weil's disease. Now, this is a facility-based study that was conducted in Mangalore regarding the symptom presentation of patients who are presented with leptospirosis. Over 202 patients, in which most of them showed a hyperbilirubinemia with elevated direct bilirubin or cholestatic jaundice picture. Now, briefly discussing about the leptospirosis, it is a zoonotic disease which is caused by the spirochete, uh, the organism named as Leptospira, and it has an incubation period of about 10 an average can go up to 20 days, and the reservoir of the organism is the rodents, predominantly rat, and which tends to contaminate the water sewers at the time of monsoon seasons, and the organism is residing on the tubules of the mice, and it shreds on the urine and exposed to the water, and patients or the people who are walking barefoot with their mucous membrane cuts, like foot walking barefoot, predisposes increase infection of the organism into the body, and by the week one of presentation or the symptom onset, the patient will be having fever with headache and myalgias. That time the leptospiral antigens will, or less PCR test from blood, CSF and urine will be positive, and subsequently in the two-third of week of presentation, they will have a urine positive in the leptospiral antigen, and simultaneously after week one there will be developmental of antibodies. And this is coming to the serology aspect, which is discussed in the as in previous slide itself. Now I would like to discuss on what is the cause of cholestatic jaundice seen in Weil's disease. So in the pattern of liver function test, there was mild SGOT, SGPT elevation only, but there was a much more elevation of the total and direct bilirubin, which is pointing towards the cholestatic picture. Now, this is a study that is conducted, which is called as the hamster model of Weil's disease. This report suggests that autopsy findings of a patients with leptospirosis showed hyperbilirubinemia states, but it does not correlate with the hepatocellular jaundice, like in terms of elevated liver enzymes. Histopathology of these moribund patients with the affected liver, it showed a partial liver plate disruption. So another thought process that can come is that with the presentation of a hemorrhage, renal failure, and jaundice, the hemorrhage part, it can lead to tissue hemorrhage that can cause elevated direct bilirubinemia. That can be the cause of the jaundice, is what another thought process that we can consider. But there was no hemoglobin drop in any of the patients that is being reported as leptospiral positive patients. And here is the mice study. The hamsters were inoculated with the leptospiral organisms, and in week one itself they were moribund, and after that their histopathological examination of the liver biopsy, it showed a hepatic cord disarray with widened intercellular spaces, and also the leptospirus organism that is localizing the disease space and hepatocyte junctions, and it causes the leakage of the bile, which contains the conjugated bilirubin, and it causes the hyperbilirubinic condition. So jaundice is resulted mainly from the tight junction destruction, and it is not a resulting of the hepatocellular necrosis and or hemolysis or a classical outflow hepatic outflow tract obstruction also. This is a diagrammatic representation in which the icteric phase of leptospirosis, the tight junctions of the hepatocytes are lost, and with the leptospies coming in, and there is biliary leakage into the bloodstream. Now, what we did for our patient, coming back to our patient, he was treated with 7 days of doxycycline, and his ARDS was treated with the positive pressure ventilation, and he had a decreasing trend of creatinine with non-oliguric condition, and it improved with adequate hydration. He was discharged on hemodynamically stable basis. And furthermore, about our learning points, Wheals disease, it is characterized by the triad of icterus, pulmonary hemorrhage, and renal tubular injury, which is causing elevated creatinine. And second thing is pattern of liver cell injury in liver injury in leptospirosis is a cholestatic pattern or the bile leakage into the bloodstream due to the loosening of the tight cell junctions. Thank you.
You all can clap a little louder. So thanks for that. I think the important thing is to look for also unusual patterns in diseases that we're used to, and also kind of justify that. Now, who are the final year PGs here? Sorry, apologize. Any hands up? Going to be final year. So those who have finished exams are happily looking at each other because they no longer can be classified as such. So Narendran is putting, okay, guys, Amrita, Narendran. I'm just going to ask this. When Belssy was presenting, because we have a bit of time, on history and examination, was there something just stuck out at that time? Something in just the basic history. And this is a run-of-the-mill patient. If you look at syndromic approaches, you have a bleed, you have jaundice, we know where we are going. She had a very good history of walking in the paddy field. So we are always got the diagnosis. Is there something that was unusual in that? Unusual means you just stop and say, okay, is there something else? Though the diagnosis was screaming at you at the end of history and exam. I'm not putting it there because if you see it again, you will know it. I'm just talking about attention to detail. Anybody? It's unusual. I'm not saying you can't find it in this patient, but it's unusual. So actually where I paused, and others can argue with me on this, was the hepatomegaly. I'll just tell you. Hepatomegaly, you can see unusually in lepto, but you may not see it also. You may not have a liver that's enlarged despite the degree of jaundice that you're seeing. Okay, so a palpable liver, you had highlighted it. But for me, that will stick out in terms of don't necessarily have to have a large, you can have liver dysfunction. But with severe leptospirosis, there may be a hepatomegaly, but you don't have to have it. Remember, we have certain patterns. Typhoid, we say we look for spleen, etc. But unusual exceptions can occur anyway. Second thing was about Wheal syndrome, which you anyway explained, and this person did have severe leptospirosis. So it's a triad, as you explained. Belssy, tell us again. It's on your slide. You told us.
Triad of jaundice, pulmonary hemorrhage, and renal dysfunction, tubular injury.
Yeah. Remember, all of you who attended the Mary Kane presentation, remember, sir, there, Dr. Eapen was talking about some kind of diagnostic modality. What was that? That he kind of helped develop for leptospirosis. What was that called? And that's what you do in the early phase. We all tend to go to serology because we have very well developed labs. What's that early? It was in your slide, but the name wasn't there. What microscopy? Dark field microscopy. And you can actually see the spirochete on that. And that used to be fairly the common thing that we would say when we were doing it. Serology did come in later. So in that slide, if you can just show the slide where you had all your examination, one slide where you said diagnostic, Belssy, below, not the clinical com. Go down again, go down. I'll stop you when some more. This one. So you can see, leptospira present in the acute stage, no? That's where you could actually do a dark field microscopy. The usual thing, when does serology become positive versus when do you see? We do serology nowadays, but there is an option for that, which nowadays we hardly use. But remember, Dr. Epen was talking about dark field microscopy and looking at spirochetes. So yeah, and then here also maybe a POCUS slide would have helped. I'm not saying we should jump to POCUS, clinical examination and history, is it? That's something. So thank you for highlighting a point that was unusual in this. Remember also exposure is not just, we all think field, and rats. We had a patient who was a plumber who used to work in the basement of a building which constantly got flooded. And there were rats there. He was walking in that bare feet and he came with lepto. So the situation is there, but where do you get walking through it is the issue. Any other questions from the audience, so to speak? Okay, thank you. Thank you so much, Blessing. We'll go on to the last presentation of the day from Medicine 5.